Good afternoon, everyone. I'm glad to be here. The Health Plans, the Association of Health Plans represents 12 member plans that are run the gamut from being a startup operational plan to plans that are offering the full range of coverage like Medicare, Medicaid, commercial, and individual coverage. So we started this venture with everyone else. I'm going to take a little bit of a different approach. I'm going to talk about this as a part of the consumer's toolbox, which there are quite a few things out there available, and Eileen mentioned a few at the beginning of this meeting, and kind of walk through how APCD fits into that category. In this world order going into healthcare reform, health plans are competing for membership based on several things, but mostly quality, cost, and networks. Now, for what I mean by quality, these are services rendered as well as the quality of the providers that are delivering the care. Cost, how do you contain costs? We have this thing called MLR. I know you've heard about that. Where the health plans are only limited to a certain percentage of their costs have to be on administrative cost. Some of you all may have been recipients of a refund based on the MLR requirements in the ACA. That's sort of moved on to payment reform, and we'll talk about that in a few seconds. And there's been a lot of change and continues to be change in networks, how services are rendered. Emphasis again on quality and an emphasis on creating a new way of delivering services and delivering care. Going forward, health plans may need to reduce provider choice in order to promote quality and price. And as we move on to the marketplaces, whether they're federal or state, we're going to see that the products are going to be very, very similar. The benefits they offer are going to be very, very similar. And so the way the health plans are going to compete are on those other things, such as the network they're using and how the care is delivered. Here we are measuring quality. Patients are looking for help in choosing quality providers. Health plans already have several sophisticated tools and programs to measure provider quality and efficiency. Eileen talked about a number of tools that are out there available as well, like Leapfrog. There's information from VHI that's already available that gives some information. HEDIS, the CHAP survey, all of those tools are out there. And certain health plans have website tools that allow members to measure performance, compare relative value, cost, and identify certain provider network arrangements like an ACO or PCMH, which is a patient-centered medical home. And if you go out on the website of some of the insurance carriers today, you can search in different ways when you're looking for a provider. I was out there yesterday just looking for some background. One of them, the way that they had you search the provider was based on quality. So they had a list from the highest to the, well, not really the lowest, but highest one as far as how many awards they've gotten, how much recognition they've gotten for certain things. And you could click on that and see exactly what those providers had done and how they were ranked higher in that regard. There are also tools available to measure cost, and sometimes that's out there today with the high deductible health plans and some of those type of arrangements. Members may have some deductibles and co-payments that they're going to need to see how much they're going to have to pay if they've got to have a procedure done or something like that. Most of the health plans will have some type of calculator available on their website to help with that at this point. But going forward, we're going to have to acknowledge that the way that we're reimbursing providers is unsustainable. because we have to look at patient-centric ways of treating patients and paying for care instead of the service-centric. So you're going to see more buzzwords about things like episode of care. You're going to see more emphasis on quality outcomes, looking at readmission rates, those kind of things. So we're going to also have to work in a new world order where there's a lot of consolidation and vertical integration going on. Everybody's getting sort of mixed together. The hospitals are working and buying up provider practices. They're also working collaboratively with health plans. And it's not your basic silos anymore. It's all becoming more of a blended marketplace. There's some examples of new network and delivery systems, and I mentioned those earlier: patient-centered medical homes and affordable care organizations. The affordable care organizations, if you don't know what those are, they share in the risk involved with, so the health plan and the ACO share in the risk. There's certain quality drivers and certain initiatives that they agree on, and that gives the provider some skin in the game, as well as helps to increase more quality outcomes for the individual patients. Then as I mentioned, there's more vertical integration. Many of these delivery system models seek to reduce choice in order to promote quality and price. They also rely on volume and economies of scale for cost savings. So I think in the future you're going to see situations where the networks may be smaller, but the choice of providers is going to be key. We're going to have high quality providers involved, and that's one of the ways that the APCD will help folks to use that in evaluation of those types of situations. Health plan and provider quality can be measured just like we had talked about earlier through Leapfrog, VHI, NCQA, URAC. There's all kind of alphabet soup out there that tells you some different things about quality. And then, as I mentioned, we also have cost calculators for members and patients to try to determine out-of-pocket costs. So what's going to happen going forward? We have this big thing called ACA up there looming above, and things are going to be a lot different in that world order than they are today. You're not going to have underwriting, so you're going to have to look at different ways to try to change cost and try to impact price for people. And the patients and members are not going to have as much skin in the game in one regard because the out-of-pocket costs are going to be limited. But they may have more skin in the game because they may become the purchaser of health insurance in some cases. So sometimes the employer is going to be the purchaser, sometimes the individual will be the purchaser, and it'll be interesting to see how that all works out going forward, because some of that will be business decisions that companies will have to make on their own. So if the patient or the individual is purchasing the health care coverage for their family, they'll need to be able to look at information and to make better choices on their own to see what's going to meet their needs the best. And if you're a purchaser for an employer, you're going to have to do the same thing and to try to evaluate the needs of your employees, what makes sense for your business model, and make those decisions, because the products are not going to be that different anymore. So how do APCs fit in? Here's a little list of different things that APCs can do. They're a tool to use. There's also going to be things that are going forward movements going forward in the future to deal with meaningful use of electronic health records. And Debbie had mentioned earlier the HIE Connect Virginia. That at this point is voluntary. That's going to house the clinical data, and that's going to be more of a real-time tool. The APCD will not be a tool, although a good tool, will not be one where you can put your name in or a patient's name in and determine, you know, all their drug allergies or something like that. This is based on claims data, and it's going to be used for doing a lot of good evaluation, but it's not the same type of tool as one where you're going to look at individual patients. But one of the questions to ask is how the historical claims information from the APCD can be used in conjunction with real-time clinical data through the electronic health records and the HIA to affect change and improve healthcare delivery. So that's what we all want. We all want a more efficient system, one in which we have high-quality providers and we have better outcomes. So we have the famous map that's been seen several times, and I don't think it shows up that well, but the darker color means that they're already out there existing, and then it goes from darker to lighter. The Virginia and West Virginia, you can see that they're all, we're in the implementation stage, and then some of these other states are already, they're thinking about it, and then the ones that don't have any color in them are ones that have not moved forward. So that's just gives you an idea of what's happening across the country. Just to see if you're awake, we're going to give you a quick review on this. The Senator Puller and Delegate O'Bannon were the ones that put the APCD bill in. As we've all talked about, this was a compromise bill. And I think the biggest takeaway is that this is a voluntary model. And Debbie had mentioned a little bit about the differences between a voluntary model and a mandatory model. But it really gave all stakeholders the opportunity to discuss what we wanted and to work together for a nice quality product. One of the keys to take away is, again, the voluntary model. It was based in part on the Wisconsin Health Information Organization, and they call that WIO. And we've had a lot of involvement from Julie Bartles, who has been instrumental in the Wisconsin model, and she's given us pretty good advice and a lot of support. Stakeholders have been meeting regularly. We developed all the organizational documents that other folks have mentioned, and at this point, as Debbie and Michael, I think, mentioned, we're finalizing the documents and getting all the original participants and founders together. So it's been quite an intense few months, and I think we've gotten a lot accomplished. One thing that you can see that APCDs will be used for, they'll take de-identified information, claims data, and assist in analysis, analyzing utilization information about specific chronic disease states, procedures, or medical events. They'll also be able to be used to compare cost efficiencies among providers and to drill down to a lower level. At this point, there's some tools out there to look at providers at a much higher level. This will allow you to drill down to the group or the individual provider in some cases. It'll also measure the impact of any changes there are in the delivery system and payment reform. So they may be reflected as the data, as you get more data with trend analysis or something like that, because an APCD, the data that it provides in and of itself, is not going to change cost or not going to change quality, but it is a tool that you're able to use to identify what needs to be done in order to change cost or change quality. So I think that's important to remember, that it's not that it's a tool, and it depends on how you use it, what the outcome's going to be. The challenges that we have is just, you can read that right here. We don't know if we'll have all the self-insured data. Some of the data that self-insured employers can get may be better at the health plan level than what they're going to get on the APCD. But in a situation, as Sarah will mention in a few minutes, if you've got multiple health plans, then the APCD is going to be a place for her to be able to get information that she could not, she'd have to add all of that together, in other words, because each health plan would have its own data, but it wouldn't be able to blend the data together. So the final thoughts today is that the health plans are committed to transparency and to providing access to quality health care at affordable cost, that we want to have quality providers, and in that regard we're incenting quality improvement. We support transparency and the tools that will be used to improve quality and assist with improving public health. We just want you to be aware that vertical integration in technology may reduce competition and increase costs, but that's not always a bad thing. That, you know, if you have a more efficient system, then in the end of the day, you may be paying less instead of more. Health plans are committed financially to the success of the APCD and also as stakeholders. So we're going to move on to Chris.